test. This is my son Caleb. Say hi to the boys and girls, Caleb.
Hi.
Caleb is here to show you that with the right teacher, even an 8-year-old boy can master the concepts that unfortunately many of you struggle with. Caleb, teach the boys and girls what you learned last night.
You mean how to fart and blame it on a baby?
No, and you have no proof that it ever happened. And that baby is prone to flatulence. No, my soon-to-be grounded son, I mean the time we talked about PROM.
P what?
You know, when we talked about PROM.
What?
Premature rupture of membranes. When there's rupture of membranes before labor, it happens at about 10% of pregnancies. Do you remember now?
Huh, P-ROM. Doesn't ring a bell.
Maybe you're getting it confused with P-PROM.
P what?
P-PROM.
P-ROM?
No, P-PROM.
Oh, P-PROM. I don't know what that is either.
P-PROM is preterm premature rupture of membranes. It's rupture of membranes before labor in a pregnancy that's less than 37 weeks gestation. So after that bit of exceptional teaching, you should be master of P-ROM and P-PROM, right?
P what?
Just wave to the boys and girls. See you next time.
Hi, I'm Dr. Mike McInnes, and it's time for our quick review. Let's get started. A 32-year-old G3P2 female at 36 weeks gestation presents to labor and delivery with regular contractions and vaginal bleeding. She doesn't have her medical records with her. The patient's vital signs are stable. Fetal heart tracing is normal. External tachometer readings show contractions every 5 minutes. So what's the next step in management? Well, the important point here is do not perform a digital vaginal exam. This patient has vaginal bleeding, and we have no information about her placentation. She may have a placenta previa, which is a risk factor for preterm labor. You want to perform an ultrasound to locate the placenta, and if there's no placenta previa, then you can perform a vaginal exam. Next, what's the role of antibiotics in preterm labor? So antibiotics are only given to group B strep positive mothers or group B strep unknown mothers. Next, a 23-year-old G2P1 female at 35 weeks gestation presents to labor and delivery with regular contractions. She noticed an increased vaginal discharge several days ago. She denies vaginal bleeding. She has a temperature of 101.3. Urinalysis is normal. CBC shows an elevated white blood cell count. On exam, she has tenderness over the fundus of her uterus. Pelvic exam shows pooling and a positive nitrazine test. What's her likely diagnosis? She most likely has chorioamnionitis with prolonged rupture of membranes. Both of these are common causes of preterm labor. We can't tell when her membranes ruptured, but the patient did report an increase in vaginal discharge several days ago. The rupture of membranes probably led to her chorioamnionitis. Next, other than a digital vaginal exam, what tests can be performed to help evaluate the cervix to see if preterm labor is occurring? Well, you can measure the length of the cervix with a transvaginal ultrasound. Next, what are the definitions of low birth weight, very low birth weight, and extremely low birth weight? So low birth weight is birth weight less than 2,500 grams. Very low birth weight is from 1,500 grams down to 1,000 grams. And extremely low birth weight is less than 1,000 grams. So that's the end of our quick review. Now let's go back to Dr. Lewis.
So let's talk about the tocolytics in and of themselves. So our first category are the beta mimetics. Now these are also beta adrenergic receptor agonists, and they're used fairly often. The two drugs that we talk about are ritodrine and terbutaline. Now uterine myometrium is composed of smooth muscle, and the beta mimetics bind to the beta adrenergic receptors on the muscle and cause an increase in intracellular adenylyl cyclase. Now this will then ultimately result in a decrease in intracellular calcium. So you'll notice when we have a lot of drugs that deal with affecting muscle cells, it's usually that we're affecting intracellular calcium. So in this case, we're decreasing the intracellular calcium, and this will ultimately decrease uterine contractions. Now, both ritodrine and terbutaline are effective, but still, they only prolong pregnancy for about 24 to 48 hours. Adverse effects include a tremor, tachycardia, headaches, anxiety. Very, very rarely you can get very serious pulmonary edema. Ritodrine is given as a continuous IV therapy. Terbutaline is given as 0.2 milligrams subcutaneous and it's loaded about every 20 minutes for 3 dosages, and then for maintenance therapy, you give it every 3 to 4 hours. Now, the FDA concluded that the risk of serious adverse events outweighs the potential benefit to pregnant women receiving prolonged treatments with terbutaline beyond 48 to 72 hours. Well, we only get 24 to 48 hours of benefit anyway, so there's really no reason to continue this beyond 48 to 72 hours. So remember that you don't want to use your terbutaline beyond that 3-day mark. Now, in the U.S., you'll see a lot more terbutaline used and then the ritodrine. So realize that we do have limited data that one's better than the other, but realize that you're going to get a lot of terbutaline. And it's easy to give because you just have to give it sub-Q, and that's relatively convenient. Our next medication is magnesium sulfate. This is probably the most commonly used tocolytic, so you should know something about it. The mechanism of action is still not completely understood. Now, it probably competes with calcium, again, calcium, at the level of the plasma membrane voltage-gated channel, so we're messing with calcium and we're decreasing contractions overall. Again, we don't have very good data that proves the efficacy of mag sulfate. It's hard to do tests on preterm labor because potentially there's serious consequences to not stopping that labor. So we don't like to give placebos to 30-week gestation babies in the name of science. So it's a hard thing to test for because there's so much that could go wrong. So we don't have great placebo-controlled trials for any of these tocolytics, to tell you the truth. Now, there are some studies that show that mag sulfate really didn't show a lot of clinical benefit in regards to tocolytic effect and the effect on babies. Though it certainly has been proven to stop contractions. So it's not like it doesn't stop contractions, it's just that we haven't seen a lot of clinical benefit of it, but it's still been used for years, and I think most experts would say this is a benefit overall. Now, trials have shown that it's neither more or less effective than all the other tocolytics. So even though we use it more often than some of the other ones, it really hasn't been shown benefit comparing those two, and we do have some trials regarding that. Now, common adverse effects are less severe than the beta mimetics, and they include flushing, headache, fatigue, and diplopia. Now, relatively uncommon but very, very important is mag sulfate toxicity, and you're going to get a question on this either on the wards or in a test, so you need to know about mag toxicity, and the level you need to think of is 10. So at levels greater than 10 milligrams per deciliter, patients can have respiratory depression. They can get hypoxia and even cardiac arrest, so big time stuff. So how do we avoid this? Now, deep tendon reflexes are depressed and then lost at levels less than 10 milligrams per deciliter. Therefore, the best way to monitor for mag sulfate toxicity is not with serial serum tests. So this is the tricky part of this, is that you're not checking mag levels, though you can, but we generally don't do that so much, but rather we do serial reflex checks. So you'll see the nurse go in and check all the tendon reflexes when someone's on mag sulfate. So, and you should lose your reflexes before you get to that danger zone. So how do you administer this? Well, mag is loaded as a 6-gram bolus over about 15 to 30 minutes, and then the maintenance is about 2 to 3 grams per hour continuous infusion. Next, we're moving on to the calcium channel blockers. Now, again, we're dealing with calcium again. Whenever we're talking about inhibiting some sort of muscle contraction, we want to decrease that calcium. So here, we're decreasing the influx of calcium into smooth muscle and then getting that resultant decreased uterine contraction level. Nifedipine has been the most studied drug in this category and it's used most often. It works, again, about as well as our other tocolytics. It's better tolerated with adverse effects including nausea, flushing, headache, dizziness, and palpitations. Nifedipine is given orally, which is nice compared to some of the other medications. Again, it's loaded like all the other tocolytics. 10 milligram dose is given every 15 minutes for the first hour or until the contractions have ceased. A maintenance dose is 10 to 30 milligrams every 4 to 6 hours. Next are the prostaglandin inhibitors. So prostaglandins can increase intracellular levels of calcium and have been used for cervical ripening and for augmentation of labor. So it makes sense that one strategy to inhibit labor would be to inhibit the prostaglandins. So indomethacin, a non-steroidal anti-inflammatory drug, or an NSAID, blocks cyclooxygenase and decreases the level of prostaglandins. Now, you might recognize indomethacin as a treatment for gout, but in this indication, we're using it as a tocolytic. Now, it has very little effect on the mother. So, we give NSAIDs all the time to people. They do have serious potential adverse effects, but most of the time they're tolerated pretty well. The problem with indomethacin is that it has some potential worrisome effects on the fetus. Now, it can cause premature constriction of the ductus arteriosus, pulmonary hypertension, and oligohydramnios secondary to fetal renal failure. So one study did show an increased risk of necrotizing enterocolitis if the indomethacin is given within 48 hours of delivery. Indomethacin is not recommended after 32 weeks gestation. So remember, this is more for early gestation rather than sort of those borderline gestation preterm labor scenarios. Dosing, it's given as a 50 to 100 milligram loading dose followed by 25 milligrams every 4 to 6 hours. If indomethacin is continued longer than 48 hours, so say you've arrested your labor and you want to continue this medication because it's working, then you need to do some sonographic evaluation for oligohydramnios and narrowing of the fetal ductus arteriosus at least once a week, maybe more than that. So if you're going to continue this medication, again, remember you're not going to continue it past that 32 weeks. But if you want to continue it for a while, then you need to really keep a close eye. Make sure you still have plenty of amniotic fluid. Make sure you're not closing down that ductus arteriosus. Next are the oxytocin receptor antagonists. Now, these are not yet available in the United States, though they are used in Europe some. We all know that oxytocin causes uterine contractions. So again, it would make sense to block this action during preterm labor. Now, one agent being used right now in Europe is atosabam, and the adverse effects include hypersensitivity and injection site reactions. Now, atosabam does cross the placenta barrier, and one trial showed a trend towards an actual higher rate of fetal infant death, though most of the deaths were preterm infants less than 26 weeks gestation. So there's a little bit tricky, number game there. Well, like, it was the high mortality rate more because we have 26 weeks and less gestational age infants, or is it the drug itself causing problems? So ultimately, the FDA here declined to approve the drug due to those potential concerns of drug safety when used in fetuses less than 28 weeks. All right, we're switching gears now. We're going to go to premature rupture of membranes and preterm premature rupture of membranes. Now, recall that premature rupture of membranes is ruptured membranes before labor, but preterm premature rupture of membranes is rupture before 37 weeks gestation. Don't get that mixed up. A lot of people will think that just the regular PROM or premature rupture of membranes means that it's preterm, but no, you have to have the PPROM in order to actually have it before 37 weeks. So let's first talk about just plain premature rupture of membranes. So the biggest problem with premature rupture of membranes is how long those membranes have been ruptured prior to delivery. Now, anytime there's a rupture of membranes longer than 18 hours before delivery, we term this prolonged rupture of membranes. So what's the big deal? If a term pregnancy, so the baby's doing okay time-wise, has prolonged rupture of membranes, other than dripping amniotic fluid everywhere, what's the harm? Well, the problem is that the time of rupture of membranes, as it increases, you'll also get an increased risk of chorioamnionitis and also neonatal sepsis. So the longer you're ruptured, the more likely you're going to get infected. So another question is, do we induce labor in a term or near-term pregnancy with PROM, or do we wait and let the patient start labor spontaneously? So 70% of women will go into spontaneous labor and delivery within 24 hours of PROM. And then about 85% will get delivered within 48 hours, and then 95% by 72 hours. But that's a long time when you consider that just 18 hours is prolonged rupture of membranes. So several studies have showed that immediate induction does reduce the incidence of maternal infection and decreases neonatal intensive care unit admissions when compared to expectant management. So there is some data out there that says, well, if someone's ruptured, you can decrease morbidity by immediately inducing them. Antibiotics, because this is a controversial thing too, is that if you're ruptured, why don't we just put people on antibiotics and then decrease their risk of infection? Well, that can happen, but still, indications now is to only give antibiotics to those women who are GBS positive or GBS unknown. All right, so now we're going to talk about preterm premature rupture of membranes. So this can cause very serious problems to both the mother and the baby. So it's a common cause of chorioamnionitis, preterm labor and preterm birth. So once you, even though it's preterm, if you rupture the membranes, you're more likely to go into labor. Approximately a third of these women with